Okay, so we're going to be starting a documentation series to discuss concepts about how to document effectively. And I'm going to try to do this from the lens of reimbursement and malpractice, because that's really what's relevant to us right now. So the series stems from the fact that we don't really have a written curriculum anywhere about how to document properly in medical school. We write like our fake OSCE notes with like our low PQRST, and then our physical exam, we put in those random things to get the grades that we need. And then in residency, we learn by example, right? We learn from our senior residents learn from their senior residents and their attendings, and you realize that it varies so much. So this series is to really help bring up some basic concepts that we should use to shift our framework on how to approach documentation. So how many of you have heard this statement before? No one's heard this? Okay. Yeah, a lot of us, right? This mantra speaks to the very heart of the legal profession. So as ER doctors, we are doers, and we know that with absolute certainty that our effects and our efforts are never really adequately captured by the written word. Can the written word really show how you brought a patient back to life? So it's understandable why I hear from residents that, like, I didn't go into medicine to sit at a computer all day, spend hours writing notes, filling out charts. I went to medicine to help people. I went into medicine to be a doer. But I urge you to think about documentation a little bit differently. Writing your chart accurately is equally as important as being at the bedside. So today, I want to focus on documentation through the lens of medical legal protection. So medical malpractice attorneys can spend countless hours dissecting a chart that we wrote in only 5 to 10 minutes. They're going to scan line by line for inconsistencies, and any that they find will be blown up on a large whiteboard for the entire jury to see. And it is therefore essential that we learn how to master the art of medical documentation. And I am far from perfect in my own documentation. I learn lessons and change things up almost every day. And I totally understand how things can slide on a really busy shift or a night shift, or you just hit that point where you cannot write another note while you're working. But it's always a note that I skimp on a little bit, that I wake up from a call with a call from my chair being like, hey, can you tell me a little bit more about this case? And that feeling sucks, right? Even if you did everything right for that patient. So I just want to help you instill some good practices over the next year. So with that said, I invite you all on a journey to improve our specialties documentation practices and embrace this as a lifelong learning process. So we're going to start with the case. There's a 54-year-old male that wakes up at 3 a.m. and he has severe neck pain, so severe that he calls 911. The EMTs found him to be sweaty. His blood pressure was 180 over 100, and he was massaging the base of his neck and his head. He has a prior history of neck pain for years, but it's never been this intense. So the triage nurse documents there was head pressure, diaphoresis, and also records that he said, feels like my bones are crunching, and the pain is 7 out of 10. And then the ED physician confirms there's an absence of neck stiffness, there's no neurologic symptoms, no headache, vision changes, and no other complaints or modifying factors, associated symptoms for this patient. And then on the documentation of the exam, they have that the neck is supple, there's no carotid bruits, the GCS is 15, there's no motor or sensory neurodeficits, no focal weakness, and the blood pressure is 140s over 90s. So in the note, in the MDM specifically, the ED attending wrote, I considered and do not suspect meningitis, CVA, subarachnoid hemorrhage, intracranial hemorrhage, or a mass lesion because of these negative findings on my exam. So the patient was given 30 of Toradol. They were discharged with ibuprofen and Valium and instructed to see their primary care doctor in 2 to 3 days. They discussed with the patient that if they experience any numbness, tingling, weakness of the extremities, severe headache, difficulty speaking, ambulating, or any symptoms that concern them, to return to the emergency department. 3 days later, he's found confused and wandering in a stranger's house and brought back to the ED by the police. And a CT finds a subarachnoid hemorrhage. The CTA finds no aneurysm. So he undergoes a ventriculostomy, but is left with neurodeficits. and then seeks legal advice about filing a malpractice lawsuit. So what are your thoughts about this MDM? How do you guys feel about it? Do you feel like this attending documented it well? Is there anything you would have added? Anything you would have taken out?
I think you need to explain a little bit more why you don't think these particular things are happening. Like, you could say that, like, because of the negative findings from a physical exam, that you are extrapolating what you put there to explain. But from someone just reading this document, it doesn't really make sense why you don't consider these things. If you're not saying, like, I don't suspect meningitis because no fever, no neck stiffness, no
Right.
yada yada yada.
Mm-hmm.
Where I think we get the impression that by saying, like, because of negative findings or whatever, that people will put that together, but I don't think that comes across.
Yeah, okay. Yeah, absolutely. That's definitely one thing. And then for me, I'm also like, I've written this note before. Like, I've been the person that's written this note because I'm like, this is definitely musculoskeletal. Like, they look good to me. These are not findings that are consistent with the subarachnoid. Like, I've been guilty of this. Yeah.
Even with all of the negative, like, the story itself is very concerning.
Yeah.
Diagnostics is like just the story itself.
Mm-hmm.
And then you compromise that person and that's
Yeah, absolutely. Mm-hmm.
I'm going to play the other side of it.
Yeah.
I think it is tough and there's gray to this, but in some of like malpractice thought process, it's also a positive that they say they at least considered these things.
Yeah.
So that
Exactly.
yeah, so
Exactly.
so you can't say that this physician was neglectful in terms of they didn't think about subarachnoid hemorrhage. You didn't even consider this
Right.
in the person. So, but you know, I have to take the other side of it and say, well, you considered it, but you didn't do the tests that you're supposed to do to rule it out. So why? How did you know, Dr. Desai, this wasn't a subarachnoid?
Exactly.
So it's a tough situation, but at least the positive is that you considered it, and you can't say you were neglectful in terms of not considering it for a person that didn't.
Yeah. These are like all the thoughts that like come to my mind when I look back at a chart and I'm like, I could have written this better, right? This was not clear, but I wasn't negligent because I did think about these things. However, I didn't think that these were the diagnoses based on the history and exam diagnostic findings. All right. So now the plaintiff says, you should have suspected a subarachnoid on my first visit and done a CT scan. You didn't do any tests to rule out the problems you identified in your differential diagnosis. Exactly what Dr. Willis just said. And the defense, so the ED doc said, your neck pain wasn't really typical of a cerebral subarachnoid hemorrhage. I evaluated you. I found no neurologic symptoms or signs. I felt that your neck pain wasn't related to anything inside of your skull and didn't believe that an LP or a CT scan was necessary. I documented my findings. I discussed them with you and advised you to see your primary care doctor. Your subarachnoid could have happened after I saw you. And even if you did have a subarachnoid at that time, there's no guarantee that your outcome would have been any different. So this is what they said to this person. Do we know if that's true or not? Like, did they have a subarachnoid at that time when they had the neck pain? Probably, yes. Yeah. So that was kind of like the back and forth between the plaintiff and the defense. And the result, so an EM expert witness essentially reviewed the records for the patient, reviewed the notes, and went back to the plaintiff's attorney and found that everything kind of lined up. There were no inconsistencies with what was said and what was written in the note. And he said that the defendant did meet the standard of care and it was well documented. And so no lawsuit was filed. So with that said, I guess, what are some of your takeaways from this? Even though there was no lawsuit filed, like this is like everything is clenched, right? Like I'd be stressed out if I had to be in this situation. What's up? You had a thought, Raj?
No,
Yeah, give me some takeaways. What are your takeaways? Yeah, absolutely. Yeah, absolutely. And I've spent so much time like looking at notes after shift, like changing things around and like rewriting things that might be worded a little bit differently. Did anybody learn anything? Like, is there something that you would, I guess, take away and think about differently the next time you're writing your MDM? Yeah, Leidy.
Reading the triage documentation.
Yes.
Because you might have looked different when you saw them, if they've been sitting there for a while, like that was right after the subarachnoid.
100%.
So maybe like taking that into account when you're thinking about your story or even putting it in your documentation.
Yeah, absolutely. This is like that 2 hallway patient, right? They get triage, everywhere's full, they go into 2 hallway. There's it's a dynamic process being in the ER, and then you see them later and things are a little bit different. I totally agree. Yeah.
What Leidy said, sometimes you have to, it's really important actually to read the triage note, because what the note from that, like, they might have said something, and then maybe it's not completely wrong, not always, but I'm just saying, like, if the patient like says, I'm actually not, this wasn't why I came in.
Mhm.
You have to say, like, I try to document contrary to triage note, patient states he currently does not have.
Exactly.
blah, blah, blah.
Exactly. And I
It's clear why I didn't follow that path of that.
Exactly.
They said that it's not actually.
That's awesome that you do that. That's exactly what I do too. I write, contrary to the triage note, the patient says that blah, blah, blah. Yep.
Is it better to say the presentation is not consistent with subarachnoid or whatever, or that's still not protected?
No, you can say that. You can totally say that. Because, right, like if you look at any studies and think about the percentages of subarachnoids that start with neck pain, probably pretty low, right? Compared to that, like,
In this case, necessarily, I would say in an older type of case.
Yeah.
I would say the presentation is not consistent.
yes,
with-
yeah, you absolutely can. I don't know if it would
say
100.
consider
Yeah, you can say that. Yeah.
I think it's good to say at least that, but we should explain why, but if you don't, like Dr. Wilson was saying, it at least shows that you had a thought process. Not to kind of call it in and explain what it is afterwards, but it's better than you not putting that it's not, the presentation is consistent with it, because if you just said, oh, it's not ACS, but you don't even give a hint of why you don't
Why,
think it's consistent.
exactly.
Presentation, because it's the exam, is inconsistent.
Exactly.
Stories, and then it really leaves it up to, well, what aspect did you really consider there?
Mhm. So these are a few of the things that I took away from this case is, one, being wrong is not being negligent, right? If you did the appropriate workup based on the patient's history and exam, it's not wrong. Your documentation must support your rationale and your clinical judgment. And when discharging a patient, reread your MDM and use it as a checkpoint. This is what I do every time before discharging a patient. So I'm going to kind of walk you through what I do. My first question I ask myself in my head is, did I do right by this patient in front of me today? And after I ask myself that question, I ask myself more objective questions. Are their vital signs now stable? If they are, I document that. If they're not, I document why I'm okay with sending them home with an unstable vital, like a really high blood pressure. I would say, like, they admitted that they didn't take their blood pressure medications today. They have no signs and symptoms of end organ damage. Their lab work also does not reflect this. They said that they're going to take their medication as soon as they get home, right? That's reasonable. Maybe it's someone who's always a little bit tacky, right? That you're sending home, their heart rate is still like 105 to 110, but you're sending them home. Justify why you're sending them home. Next thing is clinical sobriety. I don't document this on every single patient, but it's the acute intox patients that come in, right? I document that they have they remain neurologically intact. They have a steady gait. They're able to ambulate throughout the emergency department before they leave. The next thing is, are they able to care for themselves, right? We're sending them home. Like, what are they going to do when they get home via ambulance? I document that there were no new complaints during the encounter, and that if there was any inconsistency with the triage note and my evaluation, I document it here. And then I write my specific follow-up and return precautions. I know a lot of times we say, follow up with your primary care doctor, and then there's no like specific time that we write. Or we say, like, if your symptoms get worse, come back, right? We're actually telling the patient more, right? When we have our chest pain patient, we're like, if your chest pain is recurrent, persists, worsens, if you have shortness of breath, palpitations, dizziness, lightheadedness, pain going to your neck, jaw, arm, we say all those things to them, right? So what I suggest is writing a dot phrase for your return precautions for every patient. So then it takes 2 seconds for you to just put it in for your chest pain patients, because you're having this conversation with them, but also writing it in your chart is really important. Because if you say, return precautions given, like, what were the return precautions? Like, what did you say? So if it's your spiel, put in a dot phrase and use that, and that'll help you. Yes.
Is the actual discharge, like, papers that you give the patient part of the medical legal?
It is part of it. It is part of it.
Because, like, in my discharge note, I don't write my specific return precautions, but I've given it in the doc rates on my discharge instructions.
Yeah, so it's in the computer, so it technically works. I'm a little bit repetitive and I put it at the bottom of my note, in my dispo note too. Yeah, one or two more questions, Dante?
How protective are the precautions as far as like import? Like someone comes over and if you don't scan their head, come back if they get word.
Yeah,
And come back adequately,
yeah.
do they didn't sue you for missing the first time?
If you documented all of your history, your exam findings appropriately, then I don't think that they have a really, like, have a case to stand against.
You can get through that at all points, but if you're documenting very.
Yeah.
Plaintiff's attorney is gonna be like, no, I'm not taking this case.
Yeah.
So that's money that they're gonna lose.
And then the last thing I ask myself is, if an outsider reads this, does this explain that I did right by this patient? And I ask this to myself because I don't like the whole like practicing defensive medicine. Like, I don't really believe in that. If we're doing the right thing for our patient and we're not cutting corners, then I don't need to practice defensive medicine because I know I did the right thing. So when I ask myself these like moral questions, I feel like that's what helps me decide if I can safely discharge a patient home and if I documented my management with this patient appropriately.